खड़ी तो रहना है, ये नहीं बोलना है कि मैं co-host वगैरह। FIST का फुल फॉर्म क्या है? FIST का
This mic is not working. Can you use this?
A beautiful morning to all the eminent personalities from all over the globe, speakers, chairpersons, committee members, participants, and dear students. It's a great honor and privilege to welcome you all to the first International Symposium on Tribal Health 2025, jointly organized by Maharashtra University of Health Sciences, Nashik, and All India Institute of Medical Sciences, Nagpur.
I, Dr. Darshan Dakshindas, faculty of Government Dental College and Hospital, Nagpur, and member of Academic Council, MUHS, along with my co-host, Dr. Neelam Bajaj, faculty, AIMS, Nagpur, shall be taking you through the scientific sessions of this symposium today.
Before we take you through the journey, as per the protocol, allow me to announce the few essential information. We would request all the delegates present here to kindly switch off their mobile phone or please take it into the silent mode. Secondly, during the session, the second floor exit and entry can be used for the exit and entering the auditorium. Kindly avoid using the ground first exit and entry during the sessions. The lunch for the faculty is arranged on first floor of the auditorium, whereas a lunch for all the delegates is arranged at the Epicureal Lounge just beside the auditorium. Before we start, let's highlight on the previous day's conference proceedings, which began with a presentation on the researches by the organizing committee members, where the key members shared their insights and extensive groundwork on the platform. Following this, the session on the global connectivity of Indian research highlighted India's increasing influence in the global research landscape and were conducted by various international delegates. It was followed by the inauguration of Blossom, which was a significant moment as it plays a foundation for the thematic discourses of FIST 2025. The day concluded with a grand inaugural ceremony, setting a dynamic and inspiring tone for the conference ahead.
Now, to open the plenary session, we welcome our esteemed chairpersons, Padma Shri Dr. Vikas Mahatme, ophthalmologist and former member of parliament, and Mr. Dinesh Wagmare, IAS Additional Chief Secretary, Government of Maharashtra. I welcome you, sir.
Who's the second speaker? I don't know.
Welcome, sir. It's my honor and pride to invite the first speaker for the day, Lieutenant General Madhuri Kanaitkar, Vice Chancellor, Maharashtra University of Health Sciences, Nashik, to present her topic. May I ask to ask?
Yes.
Okay.
Yes. We also invite the great Dr. Prakash Amte sir on the stage. He will be also speaking in this plenary session.
I request the audience to welcome our speakers with a grand round of applause.
We request ma'am to please address the audience.
Yeah.
Hello. Good morning, friends. I welcome you all to this plenary session. And I see a lot of faces, especially the students here. Friends, we have two big dignitaries here. All of you know our own Vice Chancellor, Dr. Madhuri Kanaitkar, who is heading the Maharashtra University of Health Sciences. And yesterday you must have attended the sessions, as well as most important, the tribal village. Madam, in the morning, I met one of the students and asked how was the conference going on. He said, very good. So how was the yesterday? He told me it was very good. And he said he visited the tribal village. And now he started thinking that he should work on tribal health. And that is the greatest inspiration which your vision has given that student. And Dr. Sanjeev Chaudhary, where is he? He has worked for that day and night. And that is what was the purpose, I think, from the day one it has started. Another dignitary you all know well, that Dr. Prakash Amte, a person who will never like to promote his image or promote himself. In 1973 only he started Lok Biradari Prakalpa, that is in Hemalkasa. Hemalkasa is too much interior in Gadchiroli tribal district. It is Naxalite area also. In 1973, nobody would like to go there. At that time, he started his hospital there, but not like our traditional hospital, a tribal hospital. And of course, before his lecture also, I shall let you know more about him. He has been awarded Padma Shri. the 4th highest national award and Mega Success Award also. Then at that time, I think nobody has a vision, but he earned the faith of the tribal people. That is very important because tribal people have traditional medicine system. So they don't believe others, and that is true. Somebody may come and cheat them. Most of the time that has happened and exploited them. So they don't believe anybody. So he earned the faith by living there only. Their family, the son and the daughter-in-law is there, Annaga, and Dr. Digan, the son, both are working there. They have one, what do you call it as a Vanya Jeevan, what is that? Vanya Jeevan, Annaga, what is that? Vanya Jeevan, Vanya Jeev Prani Sangrahalaya or something like that, where it's zoo type thing, but it's not a zoo really. Anathalaya, yes, because that is the proper word. Zoo is not a proper word because they treat those animals there. And they have 3 cheetahs. When I went there, he went inside the cage of the cheetah, which my heartbeat was more than 130, 40, 50, something like that. Palpitation was there to me. But he was calm and cool, and cheetah with his tongue licked his arm. And I was too much afraid, I tell you. Then he entered. Yes, okay. I think we have short of time, so let us start with the session. I shall hand over the mic to our secretary, Honorable Secretary Dinanath Wagmare. He is a tribal secretary, Ministry of Tribal Health, Scheduled Tribes, Minister of Scheduled Tribes. But recently he has been he has joined as a election commissioner, Maharashtra, state of Maharashtra. So I shall hand over the mic to him.
Good morning, everybody. Actually, in fact, I was invited as Additional Chief Secretary of Medical Education Department, but just 2 days back, I have joined as a State Election Commissioner. But Madam Lieutenant General Madhuri Kanetkar, she actually insisted that I should come on this occasion. So today we have 2 esteemed speakers, Lieutenant General Madhuri Kanetkar and Padma Shri Prakash Amteji. And actually we all, they have been introduced by Dr. Mahatmaji. Actually, Madam Kanetkar's subject today is tribal development through education, research, and awareness. And as you know, although our department is medical education and Director of Medical Education and Research, but we don't focus more on research. So there was a need to develop proper infrastructure for research in medical education. And in fact, during I was Additional Chief Secretary, Medical Education Department, and along with Madhuri Kanetkar Madam, we have developed a Center of Excellence, and actually the policy has also been declared. So this Center of Excellence basically is on the model of hub and spoke, where hub will be Maharashtra University of Health Sciences, and spoke will be we have initially identified our six government medical colleges. In fact, we are the only state that in 1 year we started 10 new government medical colleges. So in almost all the districts except Ahilanagar, we have now medical college. Even Gadchiroli has a new government medical college. But among these medical colleges, among the old medical colleges, out of 25, we have selected 6 medical colleges as the spoke. So where basically different research activity will be centered. And also the Center of Excellence will focus on digital education, capacity building of faculty, then entrepreneurship development in the form of startups and incubation program, and various other things has been actually planned in the Center of Excellence. In fact, we got funding from Asian Development Bank, and in fact, sufficient amount of funding has been sanctioned for this Center of Excellence. Among these Center of Excellence, Nagpur Government Medical College has been identified as a spoke for particularly sickle cell disease and thalassemia. So as you know, and in fact, a very good theme has been actually chosen by the organizer, MEHS and All India Institute of Medical Science, Nagpur. And whereas tribal health, in fact, this might be one of the first conference in the world to actually deal with this important subject. And actually, I'm amazed at the responses, and actually the beautiful auditorium of AIMS is full, 100%. And I'm sure that actually, particularly among tribal health, one of the major problem like the sickle cell, anemia and thalassemia is one of the major disease, and a lot of research needs to be done on this. And there is a connection between malaria and sickle cell disease, so that aspect. So wherever this malaria prone area is there, either it might be our Bandara and Gondia district, or areas in Africa where malaria is prevalent, there you simultaneously find sickle cell disease and thalassemia. So that actually connection has to be explored. And other diseases also, like breast cancer, then liver disease, and oral cancer is also quite prevalent, particularly because of the habit of tobacco chewing and other. So, and another thing is that I will not take much time. So basically, during this 3-day conference, so various topics will be discussed. And during the deliberation and discussion, so policy will be formed, and that policy will be recommended to the state government as well as the government of India. And actually, we have like tribal development department, which allocate a lot of fund to the tribal development. But unfortunately, the resource allocation is that there needs to be actually have the equitable allocation to different sectors, like health and education needs to be given more money rather than infrastructure development. Of course, infrastructure development is also necessary, but then health and education is the most important sectors which we need to do a lot of resource allocation. So actually, now I hand over mic to our first
Thank
speaker,
you.
Lieutenant
Thank you,
General
respected
Madhuri Kanit.
chairpersons, for those kind words. May I now invite Lieutenant General Madhuri Kanitkar, ma'am, for her plenary talk.
Thank you so much, ladies and gentlemen. A very good morning. I thank both the honorable chairpersons for a very good introduction to the morning, and I'm impressed that so many people have actually come right on time and we've begun. Let me start by first paying my respect and being a big honor to share the podium with Prakash Dada. In this field of tribal health, as a pediatrician, I can say I'm just a baby. I have just started taking the first few steps, and I have a lot to learn. And I've come for this conference with an open mind to learn from you all who have been at various stages and are all adults in this field who have contributed huge amounts. So let us join hands and all learn so that we can advise the government on what needs to be done, how can we take it faster to achieve what we want. So this conference basically came out of an idea that we need to reach the unreached through medical education and research. And therefore, as the Vice Chancellor, I would like to talk on tribal health through the lens of education, research, and awareness. I'll cover my talk with introduction of what the university is about, what is the vision of the university, what is research for community, and then this Blossom project itself, around which we have grown so fast, thanks to Dr. Sanjeev Chaudhary, my chair professor, and the chair professor before that, Dr. Gode, who put the vision into action so that we could really start with a bang. The university was established in 1998, is one of the largest state health universities, which started in 1998 with 145 colleges, has 614 colleges affiliated to it across pathies. It's already celebrated the Silver Jubilee in 2023. The vision of the university when I took over in 2022 was, we all sat together, and we means all the stakeholders from the assistant registrars, deputy registrars, all working as hashtag MUHS Parivar, along with all the faculty members as well as my past predecessors who'd laid a very strong foundation in the university on which we could start putting on the icing. The bread and butter was there. We needed to add the jam and the icing. So therefore, we put in a roadmap for ourselves and had the, guts to put it onto the website and push ourselves. And the entire team of MUHS has worked towards achieving it more than 100% in the last 3 years. I'm very proud to say that. And in that, while moving towards education through research, we felt an integrated research was very important. And we have to move towards that. So while I come from allopathy, my pro-vice chancellor is from Ayurveda, the DSW is from homeopathy, and my medical education department has physiotherapists. The dental research department has a dental dean. So we are literally integrated to think multilateral and think multidisciplinary. So with that, we started few initiatives, and I want to share that. Research for community was the theme. Today, there is a silo. Medical education is happening in medical colleges. Research happens in the labs of ICMR, DBT, DST, with scientists doing cutting edge research. And public health is happening in our government hospitals, the primary health centers, community health centers. The three don't talk to each other. Can we change that, was this thing that we started with. And therefore, everything that university has done since then has been with a three-pronged attack. What is in it for students? What is in it for patients? What is in it for community? And for example, the Gene Health Lab, which has been set up in Pune, tests for cancer markers and congenital diseases for all poor patients, because the Gene Health and the labs outside charge 10 to 15,000. We are going around collecting CSR. We don't know where the money will come for, and I hope the government will help. But till then, we are doing it for 500 rupees, 250, and the person heading the clinical part is Dr. Aarti Kinikar at Sassoon Hospital. We are looking at integrated research through our division of research in interdisciplinary systems of health and translational innovations, which is Drishti. My faculty from there is here, and we're already doing large projects of integrated approach to managing diabetes, osteoarthritis, anemia. We're looking for cognition in geriatrics, especially with Alzheimer's, and the antenatal care along with Garbha Sanskar. So these are some of the ideas that are going on for encouraging and entrepreneurship. We're the first state health university with Disha, which is giving a direction to innovation and entrepreneurship. So Disha is developing innovations and systems for Healthcare's Association, a Section 8 company. So this is something we are doing. And with that backdrop, the challenge came in, how do you reach the unreached in Vidarbha? And the biggest problem was tribal. And I have been very lucky to visit Hemalkasa, see some of the great work being done, and encouraged by that, I've challenged the regional center in Nasik to take on something, and the university's management set up a chair professor from the university funds, and that is how this led. But all that wouldn't have taken off unless we had the correct person, and he's a one-man army, Dr. Sanjeev Chaudhary. He took it on, he planned it. I was more a supporting and facilitator. I think the moment administrators take on facilitatory roles, that sky is the limit. So Blossom's word was coined, not out of the blue, but because GMC, GDC given the problems that were there in this area and why patients came late. And they were breast cancer, liver and lifestyle diseases, osteoporosis, sickle cell, sexually transmitted, oral cancers and malnutrition, age, gender, everyone was included and the biggest problems were taken, but that was not all. We have collected 200 data sets going into villages and absolutely found out why the health is not reaching the people. And we took it as a triple S approach, that is screening the population, trying to find solutions, and the third part, which is going to start after this conference through the NSS, is going to be adopting those 18 villages. And this, ladies and gentlemen, is what implementation and community research is all about. And let me tell you, there was no funding available. We didn't know where we are going to, and we still haven't asked for any. We've done it all with in-house resources and contribution and commitment of people, which money cannot buy. So they had the three phases: screening, solutions, and service. In phase one, a community-based cross-sectional survey was done to determine the prevalence of blossom among tribal populations. Phase two is developing solutions, where the data is now ready. And after inputs from you, we have people in this audience sitting down, taking notes from getting the expertise from all of you who are going to contribute as to what are the key areas we would like to focus on. And then alongside, we will start providing healthcare to the community. Now, how did we work out? Though it was a huge thing, it was done in a very scientific manner. We were helped by the tribal commissioner who identified 18 villages. It was explained yesterday why these 18 villages would be a representative populations, but which villages? We took inputs from the tribal commissioner because these villages were far-flung, healthcare was not reaching, and more than 80% were Adivasis. So keeping that in mind, Chandrapur and Gadchiroli districts, 8 villages were selected, Gondia 5 villages, Nagpur 5 villages. And the total population as per the census was expected to be 8,306. Give and take, people would have migrated out. And I'm so proud that the team has been able to screen more than 6,400 people, which is a huge number from this of covering 100%. This is universal coverage. The planning was done meticulously. You can see Dr. Gode, Dr. Sanjeev Chaudhary, repeated meetings because a thing of this large had never been undertaken in a multidisciplinary. We had wanted students, we were taking the healthcare workers, we were taking the health system from ASHA workers, community workers. Everyone had to involve to get this on a large scale. And they were literally going across, even you can see, sitting with the villagers and holding discussions as to how we could get them to. I think this is very important when we reach the community, understanding them and making them participate with our goals. Once we were all ready, the teams had been formed, there was a big launch, and our Honorable Minister, Cabinet Minister Nitinji Gadkari, he launched this. And after that, such little buses were hired and students volunteered. I'd like to share the response of why, when the Honorable Prime Minister says that, or yesterday our chief guest said that, abhi nahi to kabhi nahi, because the youth is ready. And let me tell you, when we started this and asked for volunteers, we stopped at 300, but we kept getting requests from students, and it would have crossed 500 of volunteers who wanted to come and work on this project. So I think this was the enthusiasm with which we set up on this. And this is again thanks to the faculty. The teams were formed, 3 groups, 30 faculty members volunteered, 300 students. We created 22 teams. There were faculty from different faculties. It was going to be multidisciplinary. So we had modern medicine, Ayurveda, homeopathy, dental, and colleges across MUHS. Chandrapur, Gondia, the deans came on board. NSS volunteers joined in, ASHA workers, community leaders and volunteers. And this is what a representative team looked like. From the chief investigator, who was the head of community medicine, and we all heard him yesterday, Dr. Sauji. We formed, all others were involved, and this is how the teams were created. And this is what we found, that learning can be fun. I mean, you know, the good old days, the Gurukul system, where students were actually being taught research methodology under the tree. They were not just taken as workers who will fill forms. They were on the way in buses, they learned research methodology. They became a homogeneous collaborated group, and a house-to-house survey was conducted. Each tribal village house in the selected village was screened. Data was collected on a standardized, designed, validated questionnaire. The examination included all vital parameters, anthropometry, their beliefs and faith, including, and then blood samples were collected and separated. So this is how they were immersed in work. At every village, either a school or if there was some village health center, those were used, or they were sitting outside and people lined up and got themselves checked up. And all along, I thought the PI wanted some catchy statements. So I said, we have a map. So those are the little pictures that you can see in this standee which went in. The map was that we at the university will provide a mentorship and build in an attitude and the students' passion. That was the map which we went on in, and we really achieved great results. So all work and lots of fun. It's not because all work and no play made even Jack a dull boy. But look at them, they were picnicking there, and you saw yesterday now he's the UPSC commissioner, UPSC chairman at Goa, Dr. Rao Rani, the then deputy registrar, and they were cooking alongside or at times trying to cross a lake. Then there were evenings when the students went out. They learned a lot which was outside of curriculum. And this was, a drink on the side being offered by the villagers. And they were all where faculty and students were serving food to the school children. So it had a lot more than just collecting data. And how was the data managed? The first approval was taken, informed consent taken, real-time data collected, entered in an Excel sheet. Data confidentiality was maintained with a backdrop, and then was the statistical analysis and the software used. So it was done scientifically. This is my high point when I managed to come from Nasik to Nagpur to Hemalkasa, spent a night in the wonderful ambience of Prakash Dada's Sankalp over there, and then went on to Hidur, driving another 4 hours, and actually could enjoy and had the pleasure of taking a bedside clinic for the postgraduates even there while seeing patients. And these were some of the memorable moments. In one of the villages, they shared with me when the doctor's team arrived, see the welcome. It was not that some people are coming, they were welcomed like this. And another time the bus got stuck and the villagers came out with a tractor and pulled it out. So these were some of the memorable moments the students and researchers went through. The results have been all compiled in a huge document or like a thesis. And I think this was where when it was given in the university, they got a standing ovation. And these are just snippets, because I would want the teams and the PIs to publish. Yesterday, I've goaded them that we must bring out before we find solutions. It was very heartening to note that 88% had access to toilets. More than 89% preferred Indian systems of medicine and local treatment or a mixed approach. 77% availed the PMJ insurance. 35% consumed alcohol, mostly Maua liquor. It was disheartening to find that 2% had absolutely no idea of menstrual hygiene. 52% of deliveries were still preferred at home. I think we need to understand these. And yesterday we heard a lovely presentation from Brazil, where how they train this. I think we need to look at that. Some of the health facts which was an eye-opener was 7.6% had a raised bilirubin, probably a trait of Sickle. 20% of men and 29% of women, even in these remote areas, had hypertension. And let me tell you, while health hadn't reached, but Lay's, chips and packets were there in every village. 20% had a raised cholesterol, 30 an abnormal waist-hip ratio, 24% had anemia, 25% had oral submucosal fibrosis. All these, of course, we've started treatment on the side. 62% of women had osteoporosis or osteopenia, and they were much younger in age. And while 38% were underweight, Alongside 15% were obese. So they are really going through this double whammy. So what were the key takeaways? A simple design, easy to replicate. I think if we all health universities, colleges start undertaking community-based research, we can make a difference. So this was through Sangam. Yesterday I spoke about a foundation that our Chief Secretary Maharashtra State has taken on, which is a synergy of academia networking with government, allied health and medical professionals. It has to be a all of government, all of society approach to take up a problem, just the way we won in COVID. It was student-centric with experiential learning. Minimal funding, maximum gains. Good data collection with a team approach. Targeted interventions which can be planned out of it. Ability to guide policy. We feel confident now. But what was beyond measure was a community outreach program by students and faculty so that we did not remain in our rooms. Sensitization of healthcare students to tribal needs. They learned to communicate with the locals. A lot of them were stimulated to maybe take on and reach out and go to these people because they need us as much as we need them. And it was an opportunity to educate local tribals as well. So therefore, this blossom has been from collaboration to a confluence to a conference to which you are all here today, and I thank you all. So please, ladies and gentlemen, have great fun at the first International Symposium on Tribal Health 25. And this is the hashtag MUHS Parivar, which stands in unison and enjoys taking such challenges further in a new method, in a new way to have a new India, a Viksit Bharat. Jai Hind, thank you so much.
Thank you, ma'am, for enlightening us, inspiring us, and delivering a compassionate message to the audience through your remarkable presentation. Thank you once again. I would now request our next plenary speaker, Padma Shri, Dr. Prakash Amte sir, to deliver his insights on the subject.
सर, तुम्ही वेळात वेळ काढून इथे आल्याबद्दल मी FIST-25 सिम्पोजियमच्या वतीने तुमचा खूप खूप आभारी आहे आणि आमचं मार्गदर्शन करण्याकरता मी तुम्हाला मंचावर आमंत्रित करतो. धन्यवाद सर.
नमस्कार. मंचावर उपस्थित सर्व मान्यवर, या कॉन्फरन्ससाठी उपस्थित असलेले आपण सगळे प्रतिनिधी. The subject of today's talk is compassion in action. So this name was given by His Holiness Dalai Lama. He met Baba twice. He had also invited to myself and Mandakini to Delhi. And one day there is a telephone call from his office. You tell about your story. The title would be Compassion in Action. And my father always believed in compassion. So he started a leprosy work in Chandrapur district, which is famous as Anandvan. Myself and my brother, we were in the same class. Aurora was a small town. And we had our education in Marathi medium municipal school. Fortunately, during 70s, there was not so much of competition. So we both got admission in Government Medical College, Nagpur. And this compassion for the tribal was not decided. We both had decided to continue Baba's work in Anandvan. But he had different plans, probably, destiny. After appearing for the final MBBS exam, we were awaiting our result. In 1970, December, he said, let us go for a picnic. And everybody, loves picnic in a forest for a couple of days. He said, we'll go to Hamragarh. The name of that village was never heard. It was not famous for anything. So we started our journey in a four-wheel vehicle. 250 kilometers distance. It took us 2.5 days to reach that place. There were no roads. lot of rivers and nalas and all. But the place was so beautiful. And it was quite cool. December, temperature was probably below 10 degrees of centigrade. So we lit a huge fire. We slept underneath the star, multi-star. And the water was clean in the confluence. Next day he said, now that we have come such a long distance, let us go and explore the area. So he took us to the first village, the tribal village. We did not know that which tribe is here lives or either whether people live in this forest, which was such a cutoff from the world. And about 15 huts and a small cart road. As soon as we went to the village, all the inmates, they came out of their huts and everybody was scared. We feel a little awkward. Why are they scared? You know, they are our brothers. But we could not understand the reason behind their fear. We wanted to have some communication with them, started towards them. All of them, 100%. Boys, girls, adults ran away in the forest. It was quite strange for us. We lived in a leprosy colony where we have seen a lot of stories of different persons, you know, driven out of their house. And at that time they were begging in front of the churches and all. But here there is no obvious reason to be scared of you, of so-called civilized men. So that's how we were just surprised. We went to the next village and to the next village and nobody stopped. We came back to our camping site, lit a huge fire. There were two differences. Number one, because it was too cold, we had all the clothes, warm clothes, and a shawl over our shoulders. And the people living there were almost digambar, without clothes. And second thing, probably the reason behind their fear might be that so-called civilized people had harassed them. So they really prefer to keep away from these people, these civilized people. So we were all engrossed in our thoughts, and then Baba said suddenly, now that you both have almost passed MBBS exam, and you have already decided to join my work, I feel that I should do something for this tribe. This is the Madia tribe, one of the most primitive tribe of India. I'm not a doctor, he was a lawyer basically. So I said, hey, I can teach them farming. I can give them vocational training. And suddenly I realized the intention of his picnic. I said, Baba, at this age, you are approaching 60 years old. And if you start work in such a difficult area, I am just 22 years old. If you start the work, I will take the responsibility. And that's all. That was the turning point in my life. You know, yes. I have never imagined that I would go there and start work for the tribal people. But his vision, Baba's vision, he had all these different able people in Anandwan, not only leprosy, blind and dumb and deaf and physically handicapped and whatnot. But this, working for the tribal was turned out to be, I am really fortunate enough to, he gave me a chance. And that was because of the compassion. Yeah. So we returned back, our results were out. Before going for internship, he said, you write to government of Maharashtra to give us some land to work. As everybody knows, it takes a lot of time. Bureaucracy, they don't reply to your application. So they took almost 3 years to sanction the land. In the meantime, जो होता है अच्छे के लिए होता है. माझी मंदाकिनी देशपांडेशी भेट झाली पोस्ट ग्रॅज्युएट करताना. She came for the post graduation in anesthesia, and I was doing my surgery. So working together on the same patient, Probably the chemistry matched, I don't know. Lot of people interested in our love story. वो ती पण सांगत नाही, मी पण सांगत नाही, पाहिजे लव ॲट फर्स्ट साइट हो सकता है. But she is from Nagpur. She was 1 year senior to me. That's why we didn't know each other during graduation. But while doing this proposition, we came to know and then started moving together. And that the news went to Baba. He called her and then asked her. By the time she had decided probably to marry me. But Baba said he is going to unknown place. तुला सांगितलंय की नाही? She said, yes, he told me. And what is your plan? Yeah, I said, I gave him promise. So immediately Baba said, promise दिया है तो इसका शादी करवा दो अभी. ये एजुकेशन चलेगा. तो my mother said, बड़ा भाई था विकास, तो उसकी शादी पहले होनी चाहिए. But Baba was practical. उसके शादी को समय लगेगा तो शायद इसका डिसीजन चेंज हो सकता है. So that's why तो मैरिज हमारा 72 में मैरिज करवा दिया. और 2 दिन के लिए जंगल में जाती है शादी के लिए. उसको भी लगा जंगल में सब सुविधा होती है, एटलीस्ट रेस्ट हाउसेस होते हैं, कुछ यहाँ रिजॉर्ट्स है, ये है. आफ्टर द वेडिंग वी वेंट टू बमरागढ़ फॉर हनीमून, वेयर देयर वाज नथिंग except forest, there was nothing. Then she realized the future life kaisa hoga apna. So 17th December, by the time she had completed her diploma in anesthesia, I was lecturing in Nagpur Medical College. And I was about to complete my MS General Surgery, but as Baba took the land, possession of the land, I left my education and I went there. Constructed our own hut, thatched hut. And she had to resign her job. And not had to, but she had resigned. She did not have resigned. But as she had given the words, she resigned the job and she joined me. That's how the beginning of this tribal project, Loka Biradari Prakalp, People's Brotherhood Project. And then we came different problems. Absolutely unknown area, no experience. We didn't know about the language of the tribal. So it was really challenging, frustrating, both. So we started going from village to village, try to understand their culture. But the language was a barrier. Madhya bhasha hi boli bhasha hai. It's really very different from Marathi and Hindi. So somehow we learned the language and we learned their culture. If somebody falls ill, what happens? They take him to the pujari. The local quack, they call him pujari. So along with so-called herbal medicine, he used to utter some mantras, ask for a sacrifice. Sacrifice of chicken, goat is all that. But it was a practice of a human sacrifice. Sometimes they used to please the god. There was a practice of human sacrifice. So it was so difficult for us to digest, how a human being in 70s can live without clothes, without food. And then we realized the problem. The pujari has his own limitations. छोटी मोटी बीमारी तो ठीक हो जाता था. That was because of the immunity of a person. But since they had gone to him, he uttered some mantra. So naturally credit went to him. So that's how the tradition continued. But those who were really serious, mantra काम नहीं किया, बलि काम नहीं किया, जाट पत्नी. They said, now you take him back and wait for his Bhagwan ki mercy. As we all were moving from village to village, from house to house, we found some of the patients helplessly sleeping in front of their house, lighting the fire. I will tell you the example of first two that changed their attitude and gave us some confidence. The first case was a case of burn. They sleep by the side of. मी सांगतो त्यांना शेकोटीला कुशीत देऊन झोपतात. टेम्परेचर इतकं कमी असतं, 10च्या खाली जातं डिसेंबरमध्ये. तर इतक्या जवळ So this one particular boy had an epilepsy. So during the attack, he fell down in the fire and had 40% burn. They took him to the Pujari. He applied some medicine and mantra, tantra, whatever it is. The wound got infected and there were maggots. So he sent him back. So helplessly crying in front of his ward. The maggots, they bite inside and you cannot remove them. They go inside the muscle and all this thing. So we requested the parents, why can't you bring them here, give us one chance. We will try to. And they agreed since they thought that now ये तो मरने वाला है तो चलो एक बार ये बोलते तो हमारा भी एक बनान ट्री के नीचे एक क्लिनिक था, बाम्बू का टेबल, बाम्बू का बेंच. But they brought him in. We gave him antibiotics, dressed his wounds. Antibiotic, we used a lot of penicillin. Penicillin lacks, no reaction anyway. It was so effective and cheap, both. And gave him Gardinal medicine, tablets for his epilepsy. And he was a virgin case, they had never taken medicine. The effect was really miraculous. So his wounds were healed. He became all right. We adopted him. He was staying with us. We learned more language from him. That's how, little bit of attitude of the people changed. ये मरने वाला था, इनके पास ले गए, बच गया. So next was more dramatic. Mouth-to-mouth publicity से a patient was carried on shoulder. Dead body जैसे लाते हैं from 30 kilometers. Tribal has a custom of helping each other. So 30 kilometers से तो माँ बाप तो नहीं ला सकते. The youngsters from the villages, by procession, they brought him to our clinic. And the man was unconscious, had fever. सब तो चले गए. We were so happy that इतने दूर से patient आया. And next moment, we realized there is no investigation. Language का problem है. How to diagnose? We referred some books. Unconscious है, बुखार है, क्या कारण हो सकते हैं? And then finally decided probably it's a case of cerebral malaria. So we had little medicine box. We gave him IV quinine, saline, glucose, and cortisone. And round the clock, one of our volunteers used to sit and watch him. On the third day, he opened his eyes and we felt so happy that our diagnosis was correct and the line of treatment was probably correct. And on the fifth day, the man got sufficient strength. He got up, took his cot on his shoulder, and went back walking 30 kilometers. So that has changed the total attitude of the people. Now the Pujari couldn't. तो मरने वाला था, यहाँ हेमल कसा लेके उसने अपनी कुटिया लेगी, पैदल जा रहा है. So the word spread, और एक साल के बाद में करीबन 40,000 patients visited हेमल कसा. But the problem was that I had left my surgery job and my wife was anesthetist. They come from every problem. Obstetric labor. So we learned how to deliver by forceps or suction लगा के निकालो. Once in a while, if the head is too big or the lie was transverse and hand was probably swollen and all these things, we couldn't do cesarean in the forest. No electricity, no operation theater. But once upon a time, they used to do the destructive surgery to save the mother and have another chance. So after much of a debate and discussion, we decided this is the only alternative, the first case of destructive surgery. So we first called the mother and father and then the husband. This is the only way. Probably we'll save the mother. डॉक्टर साहब आपको जो ठीक लगता है करो. नो ऑब्जेक्शन एट ऑल. जो ठीक लगता है, हमें कटिंग ऑफ बेबी से ठीक लगता है. We could never imagine that. But it's a blind procedure, never done before. और कंदिल का लाइट, हरिकेन लैम्प अभी कंदिल देखा नहीं है किसी ने. इलेक्शन सिंबल है लालू प्रसाद का. कंदील नाही, आजकाल कोणी पाहिलं नाही ना कंदील होता. So in that light, we removed the baby. I mean, the procedure I don't explain. It's not. Then in the morning, the lady said, "Not now, the baby is dead. What's the use of staying here?" She walked back 25 kilometers just after the delivery. They are already malnourished. The hemoglobin is below 10. But still, a tremendous willpower they have and tolerance of pain. Before going, Manda, my wife said, "Next time if you come, if you become pregnant, be regular in checkup." And in the last month, we admitted her after 2 years. And she delivered a normal baby. अच्छा अच्छा लगा, थोड़ा सा हमारा गिल्ट कम होगा. तो देन मैं ऐसे लगा कि इतनी जल्दी उन्होंने परमिशन कैसे दिया कि कच्चे को काट के निकालो, काट दो. तो इसका कारण ये था, if at all the baby delivered normally, the mother had no milk, suppose. The baby died after 2-3 days or a week. ये थोड़ी सी पहले मर गई. मेंटालिटी कैसी होती है ना, लेकिन मदर तो बच गई. So the next case ऐसे आते गए, fracture. How to diagnose fracture? No electricity, that's why no X-ray machine. You can just see the swelling around the injury. By the time I knew that they have a tremendous tolerance. तो जहाँ भी swelling है, उसके ऊपर नीचे पकड़ो और घुमाओ. So if there is a fracture, we could feel the friction. The diagnosis confirm हो जाता था. प्लास्टर ऑफ पेरिस का पाउडर लेके गए थे, गॉस पिक्स के ऊपर डाल के उसको प्लास्टर लगा के, तो 1-2 महीने में ठीक हो जाता था. मतलब किसी को ना नहीं कहा, बिकॉज एक बार तो विश्वास आ गया लोगों का, तो कहते हमें कहते मैं स्पेशलिस्ट नहीं हूँ, कैसे कह सकते. डेंटल प्रॉब्लम आ गया, बहुत दूर था. एक सेट लेके नागपुर से, एक्सट्रैक्शन से 32 में से 1-2 दांत निकाल लिए तो कोई नुकसान नहीं होता, लेकिन पेन चला जाता है. तो रेगुलर डेंटल का काम कर रहे थे. एक बार केस आई बेयर बाइट. इट्स अ वेरी थिक फॉरेस्ट, लॉट ऑफ केसेस ऑफ बेयर बाइट्स, बहुत सीवियर होता है. बेयर इज डेंजरस देन टाइगर एंड लेपर्ड, अनप्रेडिक्टेबल है. तो ये केस कैसे 60 किलोमीटर से होता है. द कंडीशन वाज दैट द आईज वर पंक्चर्ड, बोथ द आईज, एंड द स्कैल्प वाज हैंगिंग बैक. और 10-12 लोग उसको उठा के ले गए. कुआ कोडी में शेवटचं गाव आहे, लास्ट विलेज, महाराष्ट्र का भुजमाड. तो फर्स्ट टाइम देखा, या मेडिकल कॉलेज में पहुंचते नहीं ऐसे बेयर बाइट की केसेस नागपुर में. तो उस समय एक विजिटर आया था, डॉक्टर था, इंटर्न. शाम हो गई थी. बाय द टाइम वी वॉश्ड हिज वुंड, स्कैल्प को भी वॉश किया, रख दिया. इट नीडेड स्टिचेस. So there was no anesthesia, no machine, nothing. तो रिलेटिव्स को एक्सप्लेन किया कि इसको स्टिचेस देना पड़ेगा. तो स्टिचेस उनको समझा भी नहीं. वहां सिगड़ी दी, सिगड़ी पे बॉइल किया, लिनन थ्रेड जो पुराने जमाने में था, कॉर्ड नीडल. फर्स्ट स्टिच, नो रिएक्शन फ्रॉम द पेशेंट. So I started giving stitches out one after another. After about 100 stitches, he said, "How many more?" Tremendous tolerance, height of a tolerance. And he gave him a lot of penicillin, and after 7 days he went back walking, holding the hand. So, but this is a half story. Next year, some other fellows from that village came. And out of curiosity, I asked him, "Oh, last year का patient कैसा?" वो मर गया. How did he die? Oh, इतने severe attack में मरना चाहिए था. तो अभी कैसा मरा? Because he was blind. They explained. He couldn't go to the forest to collect his own food. Neither he could take part in hunting activities. The relatives थोड़ा देते थे, but it was not sufficient. So gradually he became so weak. आपण त्याला भूकबळी म्हणतो. He died of hunger. It was really a shocking news for us. After the independence, 25 years of independence, man dying of hunger because he was blind. So that inspired us to do the cataract surgeries. There were a lot of cases of cataract patients in the village. As long as they could see, they could go to the forest and collect their own food. But once they become blind, elimination. So we bought the instruments. पुराने जमाने के थे, phonograph is nice. आजकल लोगों को पढ़ते भी नहीं वो, और किताबें लाए, इंस्ट्रूमेंट्स लाया, एक पेशेंट लेडी को तैयार किया, he was completely blind. और we were all tense. बोला था ऑपरेशन करेंगे, क्या होगा बाद में, तो वन टेम्पररी एक ऑपरेशन थिएटर बना के उसको स्टरलाइज किया. दो लोग टॉर्च पकड़ के थे, दो लोग कपड़ा पकड़ के रेस्पिरेशन ना गिरे इसमें, और वैसे ऑपरेशन किया, एरिडोक्टोमी किया, एक स्टिच दे दिया, छोड़ दिया ड्रेसिंग करके. नेक्स्ट डे अगेन ऑल ऑफ वॉलंटियर्स गैदर देयर, देखना चाहते कि क्या है रिजल्ट, उसमें ब्लीडिंग हुआ है क्या, इन्फेक्शन है क्या. अब वो द आइज वर क्लियर एंड शी काउंटेड द फिंगर. हम लोग बड़े खुशी से नाच रहे थे कि ऑपरेशन ठीक हुआ. और आफ्टर 10 days +10 जो होता है ना वो उसका रिप्लेसमेंट ऑफ द लेंस, गांधी जी का फ्रेम वाला छोड़ 5 रुपए में मिलता था चश्मा. शी वोर दैट, नीचे लंगोटी ऊपर चश्मा और पैदल जाती हुई थी. उसका एडवर्टाइजमेंट हो गया कि यहाँ तो अंधे आदमी का भी इलाज होता है. दे स्टार्टेड वन बाय वन दे कमिंग फॉर ऑपरेशन. तो इस तरह से मतलब ये करते कि समय कम है, बहुत सारे केसेस ऐसे, मतलब आई एंजॉयड दैट चैलेंजिंग वर्क. सेटिस्फैक्शन मिलता है कि हमारे भरोसे लोग आते हैं और अपने कुछ कुछ कर सके. क्योर नहीं किया था लेकिन उसका पेन तो कम किया. एनीवे देन वी डिसाइडेड टू स्टार्ट अ स्कूल फॉर देम एंड मेक देम अवेयर ऑफ देयर राइट्स. एंड देन यहाँ कोई एजुकेशन नहीं था, जीरो एजुकेशन, इसीलिए सब बाहर के लोग उनको रूल कर रहे थे. और 76 में स्कूल स्टार्ट किया. पहले तो उसका विरोध था, लेकिन 3 बच्चे 12th तक गए, उसमें से 2 ने बोले कि बहुत साल पढ़े हम लोग, वापिस चले गए. एक को फॉरेस्ट गार्ड बना, एक टीचर बना, और तीसरे को मेडिकल कॉलेज नागपुर में एडमिशन मिला. एंड ही केम आउट एज गायनेकोलॉजिस्ट, एमडी गायनेक करके वापस आए. एंड ही इज स्टिल इन गढ़चिरोली डिस्ट्रिक्ट वर्किंग एज मेडिकल ऑफिसर, क्लास 1 ऑफिसर है. कन्ना बड़ा भी. सो दैट वे इतना सेटिस्फैक्शन मिलता था कि हमने गए किसके लिए थे. देयर वाज नो प्लानिंग, नो फंडिंग, काम करते जाओ, काम बढ़ते गए, वॉलंटियर्स मिलते गए. लास्ट थिंग, ये जो डिस्ट्रक्टिव सर्जरी का मैंने जो आपको बोला, 2003 98 में मेरा बेटा अभी डॉक्टर बन गया, डॉक्टर दिगान. उसने अपनी शादी नहीं बनाई तो फिर मैरिज ब्यूरो से शादी तय हुई. डॉक्टर आना का थोड़ा सा उभी रहा था, ही इज देयर माय डॉक्टर इन लॉ. तो उसको मेडिकल ग्रेजुएट लड़की होना था, तो गायनेकोलॉजिस्ट फॉर्चुनेटली. तब से अभी ऐसे ऑब्स्ट्रक्टेड लेबर आ गए तो मंदा के लिए एनेस्थीसिया देती है और आना का सिजेरियन करके दोनों की जान बच जाती है. सो दिस इज अ कोइंसिडेंस. देखिए, काम करते जाओ, अच्छा होता है. So that way we are so fortunate, both the sons and daughters-in-law are working, carrying on the work. We are all, हम दोनों जो रिटायर है अभी, बिना पूछे सलाह नहीं देते, तो कंडीशन हमने अपने ऊपर रखी. और उनके बेटे वो वहीं पढ़े थे. अभी फर्स्ट सन गॉड डॉक्टर घोड़े की कृपा से वहाँ उनके कॉलेज में अमरावती में फर्स्ट इन बिजनेस का है अभी. सो अर्णव इज द फर्स्ट ग्रैंडसन एंड 4th जनरेशन ऑफ बाबा आमटे. He has interest in medicine as well as animals. हो गया समय मेरा? Okay.
नहीं लेकिन
We are all orphan animals. That includes leopard, bears, and snakes and crocodiles and whatnot. Their mother was killed and eaten by them. But all these animals have become member of my family. My grandson, Arno, 1 minute हुआ रहा. Since childhood, he loves animals because he was moving with me with the animals. So still today morning we go for a walk with the leopard, and whenever he comes for holiday, he joins me. Leopards recognize him after 4 months also. So that way, health, education, and animal. So thank you again, Madhuri Dey, आपके साथ शेयर करने के. डॉक्टर घोड़े मेरे पीछे पड़े थे, डॉक्टर चौधरी, एवरीबॉडी. एक्चुअली प्रेजेंटेशन कैसा करना है, क्यों करना है, उसकी भी कोई मतलब इतने प्रिमिटिव हम लोग. लेकिन ऐसे इन्विटेशन आते हैं तो कहीं जाता है, थोड़ा सा कुछ बात करते हैं। कल यहाँ एम्स के 10 बच्चे यहाँ अशोक में मिलने आए थे, बड़ा अच्छा लगा। So anyway, the last thing is that जब भी आपको समय मिलेगा तो हेमल के साथ विजिट कीजिए। आनंदवन पहले है, बाद में हेमल के साथ। Thank you very much again.
Thank you. Thank you so much, sir. We all are really fortunate and glad to hear from a person who himself, not only him, but his family has been serving the tribals in India. Thank you, sir.
And I see that the audience is more hungry for your words. So we still have 4 minutes as per our schedule. So with the permission of chairpersons, we can open this topic for discussions. And if there are any questions, mics will be provided to you. Please stand in your position. If you want to ask something to our eminent plenary speakers, especially I see more than 50% of the hall is filled by students. So if they want some guidance, they can ask questions to our plenary speakers. Yeah. Can you please provide the mic to the person in black jacket?
Good morning, sir. Myself, Rishikesh Ippar. My question was, आपके साथ हम जुड़ कैसे सकते हैं? क्योंकि स्टूडेंट्स है, हमारे हॉलीडेज वगैरह रहते हैं, तो हम आपके वर्क के साथ जुड़ कैसे सकते हैं? As a volunteer or?
So he wants to ask how he can join you, sir, in your good work.
Actually, my son and daughter-in-law, both they look after the hospital. And we have got 2 recognized seats for pre-PG rural internship. So every year 2 doctors join our project. Otherwise also you can come and see first. First thing is that you must visit the project and then decide about it. Don't भावनेच्या भरात आपण काही करतो असं नाही. Visit the project, have a discussion. एकदम नाही तर
प्लॅन चेंज होण्याच्या अगोदर केलेला बरं, सर. Thank you, sir.
Yeah. Can you get the mic in the middle row? Yeah.
गुड मॉर्निंग सर. ॲक्च्युली मला हा प्रश्न आहे की आत्ताच कानिटकर मॅडमनी त्यांच्या सेशनमध्ये सांगितलं की दे आर प्लॅनिंग टू कोलॅबरेट ऑल 3 पिलर्स ऑफ हेल्थ सिस्टीम, लाईक पब्लिक हेल्थ डिपार्टमेंट म्हणजे DHS ज्याला म्हणतो, मेडिकल एज्युकेशन आणि ICMR रिसर्च. तर मग याच्यावर इमिजिएट किंवा काही आता प्लॅनिंग आहे का, किंवा मग कसं करता येईल याच्याविषयी जाणून घ्यायचं होतं. आणि त्यानंतर मॅडम एक रिक्वेस्ट आहे, आदिवासी जीवनावर एक छोटीशी कविता आहे, मी सरांसमोर म्हणू शकतो का? नाशिकला मी जेव्हा होतो तेव्हा एक अनुभव आला होता, त्यावर एक आहे. तर मग ह्या 2 गोष्टी चालेल का?
I think प्रश्नाचं उत्तर आधी देते. Your question just to the thing, he wanted to know how we can combine health, education and research. That is exactly why, like the principal, our additional chief secretary mentioned, that is why we've set up this center of excellence, and where all to begin with we've chosen these 6 medical colleges. We're going to keep adding more, but along with that we've also added the labs in this. So we already have an MOU with, say, CDFD, we have it with NARI, we have it with NIV. So we are making these things where students can go and train themselves. So education research combination can occur. IIT Mumbai and the MedTech Hub. So we've done all these things in place. But finally what will happen is when it translates into healthcare, for that, unless in our this thing, and this is my request which I've been telling all the unless we have the health and education under one umbrella, like at the center, Ministry of Health is one. Here we have very too clear-cut demarcated, and we don't really, for simple thing, child health. You have the ICDS also, you have this thing also, you have the education department. Everyone is trying to do it, but it doesn't really translate. So that requires a policy thing, and I'm sure we'll give that suggestion to the government. But I'd like to, if Valmare Sahib can.
Chief Secretary at Magmare, Dr. Dinanath Magmare.
Yeah, basically, like, in fact, public health and medical education can always be one single department. And at Government of India level, Minister of Health and Family Welfare, they look after both the public health and medical education. But then education department as such, so it comprises of like primary education, so primary, secondary, that has to be totally distinct. And higher and technical education department, actually, it is also distinct. But then medical education and health and public health department, so and the research. So these are basically, in fact, at the Government of India level, it's only one department. But at the state government level, we are two different departments. We are the only state in India where medical education is a separate, medical education research is a separate department. And now, actually, that basically interface between medical education research will be facilitated with the Center of Excellence, which is coming up now.
I'll just add one more this thing on it, is that with new colleges which are being opened up in existing civil hospitals, what we've done is from the NMC level, for the people who are in faculty, we are changing the TEQs so that clinicians with postgraduate degrees who are working there, they become part of it, and I think that will help amalgamate, because the primary health center, community health centers to the district hospitals, which are now becoming medical colleges, I think the integration might happen better if we break the silos.
Thank you very much. And we have the eminent personalities with us today, the whole day, so you can all discuss in person.
Last question.
Yeah, we can take one last question.
Good morning. Myself, Dr. Manisha Deshpande, Principal of VSPM's College of Physiotherapy. Thank you, Madam Kanetkar and Dr. Amte sir, for enlightening us for the tremendous work which have been done for the... Yes, Madam, have you heard?
Yeah.
Yeah.
Just
So
take your question.
Yeah. My question is like first two phases of the Blossom already have been completed. And I had initially requested Dr. Sanju Chaudhary sir also to involve physiotherapists for this project. And now when the services you will be starting, so my humble request is, please let us join, because already the assessment is done, and if any rehabilitation work is to be needed, we will be very happy to join the project.
I really appreciate that input, and that will be taken 100%, because our thing, we found out a lot of musculoskeletal problems which require, there's no physiotherapy outreach in the periphery. In fact, I would encourage you all to create, how to create digital technology to help for simple problems. So, and we would definitely involve, Dr. Chaudhary is working with our DSW, so that these 18 villages as a model test this thing, we will be giving the service, and physiotherapy will be part of it.
Thank you, madam.
Thank you. Thank you to our esteemed dignitaries on the dais. Today's plenary session, I'm very sure, has created a lasting impact and inspired many of us. I would request our chairpersons to felicitate our esteemed speakers for the plenary session.
I request the chairpersons to please felicitate Dr. Prakash Amte sir. I request Professor Caroline Stephens and Professor Leon Toshililo, along with the speakers, to please felicitate our chairpersons. Yeah, they're there only. Professor Caroline Stephens is Professor of Environmental Ethics, Slovenia, and Professor Leon Toshililo is Professor of Pediatrics and Hematology, Democratic Republic of Congo.
We are felicitating our chairpersons.
Thank you, Dr. Vikas Mahatme sir and Mr. Dinesh Wagmare sir.
Thank you so much. Thank you to all the esteemed speakers and chairpersons for this extraordinary plenary session. Here we end the session. This will be followed by the scientific session very soon.
Today's scientific session one, the theme being lifestyle, tribal tradition, and taboos fostering diseases will start soon. I request Dr. Anil Deshmukh, Dean, PD MMC Amravati, and Dr. Jayanti Shastri, Chief Professor, Maharashtra University of MUHS Mumbai, to please come on the stage. I request the chairpersons to please come on the stage. And we will soon witness Dr. Anne Chang's lecture. She will be talking on disparities of respiratory health among Australian Indigenous people. I request the audience to please be seated. We will soon be starting with Dr. Annie Chang's lecture.
We are very shortly starting with the scientific session of the day. I request the chairpersons to please come up on the stage. Dr. Anil Deshmukh, Dean, PDMMC Amravati, and Dr. Jayanti Shastri, Chair Professor, MUHS Mumbai.
Check. Check. Hey, check. 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 Hey, check. Check.
The audience is requested to please be seated. We are starting with the scientific sessions. I would request the chairpersons to please take their seats. It seems we are still... I would request the audience to kindly settle down for the scientific session. A humble request to all the audience to kindly either switch off their mobile phones or keep it on the silent mode. The theme for today's scientific session is lifestyle, tribal, tradition, and taboos fostering the diseases. We will be conducting 2 scientific sessions, pre-lunch. Our chairperson has arrived. Shortly, we'll be starting with the session. I would request the speaker, Dr. Annie Chang, Professor, School of Medicine, Queensland, University of Technology, Australia. Most welcome, ma'am. Please welcome the speaker with a great round of applause. This is the first, ma'am is the first speaker for our first scientific session of day 2, FIST 2025.
Check, check.
The lights can be turned off.
Check.
Audience lights can be turned off so that we create an aura, a decorum for the scientific session.
Check. Check. Check.
Namaste. Can you hear me? Namaste. Good morning, everyone. 3/4 of the room have left, so it's a bit hard to follow the plenary session. But I'll start off by acknowledging the tribal people of the lands and all the indigenous people of the world. And I want to congratulate Dr. Chowdhury and the faculty for this amazing mission and the vision that they have in trying to improve tribal health. And I thank Dr. Chowdhury and Madam Kanika for this very kind invitation. And it is indeed an honor to be here. So I've been looked after very well, met in the airport by Dr. Santosh Sajan, and also been looked after very well by Dr. Anish Loya. We were taken yesterday or 2 days ago to the dental college where the mission for serving Aboriginal or tribal people was very palpable. So I'll put into context the indigenous population of Australia. So you can see on the top blue line, the lifespan of indigenous Australians versus the bottom blue line, which is the indigenous people. And there's a gap about 8 to 9 years. In context, this is the lifespan of Indians, and you can see that the Aboriginal Australians are very similar to the Indians, which is different from the non-Aboriginal Australians. So again, in context, this is where I've done kind of my Aboriginal work for close to 30 years now. So you can see that we go into very beautiful lands where the Aboriginal people live, but they're pretty remote. And you can see that we actually go by roads that require four-wheel drive. So the people live in very small communities. You can see it's very sparse. You can see the houses there, but it's very beautiful lands. And we fly over to the communities and travel in cars where you can see the dirt on the cars after we come back from our trips. So over the next 18 minutes now, I will talk about 5 things. What is the lung health disparity? And why is lung health so important? And then I'll talk about some of the probable reasons and the impact of the studies that we've done among Aboriginal people to global health. And lastly, we should always end with the future and hope. So I can't talk about everything about lung disparity, but I'll just highlight some of the things. So obviously I'm a respiratory physician, so lung health is my key thing. And you can see that at least in the young population, respiratory health is the most commonly reported problem by Aboriginal and Torres Strait Islanders. And we know that 1 in every 3 people report long-term lung health. They account for 9% of the death of Indigenous people. And 1 in every 3 Aboriginal children have bronchiectasis, which is a chronic lung disease. And the gap for bronchiectasis in Aboriginal people is like 22 years between Aboriginal and non-Aboriginal, whereas for cardiac disease, it's only 9 years. And statistically, hospitalization is actually really high. So you can see here on the first bar that the stark contrast between Aboriginal people in the blue bar versus non-Aboriginal children in the orange bar. And the 2 big gaps are in the first few years of life as well as in the later years of life. If you look at hospitalizations for respiratory infections, again, you can see the gap as well as the deaths for respiratory disease is much higher in the Aboriginal population. So why is lung health so important? So we all talked about achieving equity, etc. But as a pediatrician, we all know that you have to start when the kids are young. In fact, you have to start from prenatal among pregnant women to achieve good adult health. So I'll talk about some of the things. So we know that for respiratory medicine, when you have a chronic cough or you've got chronic short of breath, it actually impacts on you. But lung health also impacts on all-cause mortality as well as cardiovascular health. And I'll show you some of the good data that has been done. So your lung function as an adult is very much set in childhood. So if you have poor lung function as an adult, it's because you started off badly in childhood. And we know that chronic red cough or chronic productive cough is the independent risk factor for cardiovascular disease and cardiovascular events, which includes strokes. And the duration of your chronic cough impacts on your lung health, and I'll show you some data on that. And how do we measure lung health? It's predominantly not just by symptoms, but also by lung function. And the 2 things that we measure is what we call FEV1, which is expiratory flow in 1 second, and forced vital capacity. And these 2 things are a predictor of future mortality in adults. And the studies that have been done include people as young as 35 years of age. And this is the data. It's not my data. It's data published 6 years ago now. It's a huge data set across the world. And it included close to 127,000 people across 17 countries. As you can see, the people were aged not that old, 35 and above. They were prospectively followed up for close to 8 years. They defined lung impairment as a ZAC score of less than 0. So a ZAC score is a deviation from the mean. And clinical abnormality is a ZAC score of less than -2, but they actually took a ZAC score of less than 0. And you can see in this study set showing that if you've got mild impairment, which is not clinical impairment, you actually have increased all-cause mortality. And you can see the gradient. The more severe your lung function is, or the poorer your lung function is, the higher the mortality. And this is depicted very nicely in this graph. You can see the darker blue ages is the more severe impairment. And you can see for all deaths, there's a graded mortality. And for respiratory, it's obviously very obvious, but have a look at cardiovascular and all cause. So in these data set, there is undoubted that your lung function is a predictor of all cause future mortality. And when they dived into the data set, they found that no matter whether you come from a rich country or a poor country, whether you live in urban or in rural regions, the data was the same. if you look at the population attributable risk of impaired lung function, you can see over there, it's close to 25%. So it is huge. In fact, what they also found was it's actually larger than other things that we know that impacts, which is tobacco use, previous cardiovascular disease. I'm not saying that it is more important, but the data actually shows that the effect is actually greater than that. So to try, when we looked at this in our Aboriginal population in Queensland, we've got a specific program called the Indigenous Respiratory Outreach Program, and we also found the same set of findings as that was shown in the paper that I previously showed. So to change things, we really need to change your lung function as a child, because this is pretty old now around the world, at least as respiratory and cardiac people. We know that your lung growth starts from birth, and you've got the normal decline. So if you start at low lung function, you decline faster, as well as you die earlier. This is a study done by Australians, where they looked at the duration of cough and the lung function. On the x-axis is the duration of cough, and on the y-axis is the lung functions. The longer you've been coughing, the worse your lung function. So we have to take cough very seriously. So what are some of the probable reasons why the Aboriginal people have poorer lung health? Everybody knows about social determinants and risk factors like tobacco smoking and poor housing, but they only account for close to 50%. So there's another 50% of reasons why they have poor lung health. So there are things like genetics, epigenetics, environment and exposures, the social determinants I spoke about. But the things that you and I can make a difference is, in a clinical sense or in a public health sense, perinatal nutrition, prevention of respiratory infections, and good clinical care, which I'll come to in a little while. So is there a biological reason for this? And the answer is clearly yes. So we all grow antenatally, but in the lungs, it actually develops postnatally. So prenatally, those things on the box shows the features that affect your lung growth, but postnatally, the other features also affect your lung growth. And the lungs continue to grow throughout childhood at the maximum rate before you reach adulthood. So we have to attain full normal lung growth, and to do that, we have to encourage things like nutrition and prevention of respiratory infections and inflammation. So this is an animal study showing you how nutrition is really important. And the key thing I focus here is what a lot of clinicians can do, which is prevention of pneumonia. And this is a study, it's a systematic review done by Andrew, who was one of my PhD students. And you can see that the effect of pneumonia on your lung function is pretty high, between 0.29 to 1.8. So if you can prevent pneumonia, you're going to actually encourage a proper lung growth. So in the Aboriginal population, we also looked at this, and again, we actually found a significant effect, and in fact, the effect was pretty large, but the larger effect was actually prematurity. So we have to tackle prematurity as well if we want to actually attain full lung growth. You can see the effect of household smoking was there, but again, it was not as large as prematurity or pneumonia. So people think, is this the chicken or the egg? Is it because you're just prone to get infections? But this study done by Heather Zha's group in Africa showed that it's actually not just because you were born like that. So this is a study done when they collected data from pregnant women and followed them up. And they did lung function at 6 weeks, and then they did lung function when they're older. So you can see there that in Heather Zha's and team study, the independent factor of infection is actually really important. And the more infections you have, the more severely affected your lung function is. So we really have to prevent these things to attain normal lung function. So one of the other reasons is that Aboriginal people have very early infections. This is pretty old data now, showing you that the nasal secretions of Aboriginal people harbor dense bacteria in their nasal space much earlier than urban non-Aboriginal people on the other box there. So why are some of the things that has happened? And this is through my personal experience. Firstly, in research, people do poorer research in amongst Aboriginal people. What I say, poorer research, lesser research, and inappropriate extrapolation. And I'll show you some of that. The second thing is they have altered standards of care. I've always said that the poorest deserve the best care, and good enough is not sufficient care for people who actually deserve the best. So some of it is true racism, some of it is institutionalized or personal, some people are very well intended but they don't know how, and or some of them are just poorly educated on cultural issues. So I'll give you an example of asthma. So before we did a study in the Torres Strait, this was what was published in Australia, was city kids wheeze. The incidence of asthma in Aboriginal communities is almost non-existent. Yet, the data that they showed was actually based on very poor response rates of 50 to 80%. The questionnaires were not locally adapted to the language. When we did the study, we had local support. We had a 98% response rate. And we showed that the rates was 15%, which is the rate of what we see in the urban population. So if you do poor quality research, you end up with poor data. So you have to do good quality research. And the other thing is you got to do culture safe research. All research has to be done in collaboration with the local people. You got to do the research that helps them. So this is a paper published not that long ago saying that Australian Aboriginal people have 20% lower lung function. If you take a lower reference rate, you're going to end up with low references, and that will be a disservice to the people. But look at their research. They match for X-ray and anthropologist, but they actually did not fulfill the criteria for actually doing lung research. So we have to do first no harm when you do research. But when we did our research, we found that the lung function of Aboriginal people were definitely not 20% lower. In fact, it's very close to the normal population. So when we do research, you got to ask, what is the point? You cannot do research just for the sake of doing research. You must, what we call in Australia, pass the PAP test. And it's got to be from their perspective. It cannot be from our perspective. What about standards of care? So I'll show you this example. So this is a very well-meaning doctor in the community who said to me, and wrote this letter, in fact, this is a child who has bronchiectasis. She was 12 years of age. And see what he said. He said that there's nothing much you could do. Yet, we know very clearly that we can actually reverse bronchiectasis. He was well-meaning, but he just did not know. So we got to educate ourselves before we go out to the communities as well to make sure that we're giving them the best service. And this is another example. This child had pneumonia 3 times or 4 times, and there was a delay of 3 to 4 years before she was even referred to us, and this child actually had mucoepidermal carcinoma, as you can see in the picture there. So, you know, when you do good research amongst the people who wants the research, you actually can contribute to global health. And I'll just give you a couple of examples. In all my research, I try and include the Aboriginal people as well, because if you do not include people who actually deserve the research as well, you cannot actually convince them that this is actually good for them as well. So the first study up there was a study on chronic cough, and we've now published on how to manage them, and we included people in the Aboriginal communities and its impact on cough guidelines. The other paper further down is a paper looking at long-term use of the azithromycin for bronchiectasis, and it's really changed clinical practice, and I'll show you the data. So this is the data, randomized controlled trial in Aboriginal people only, because they were the people that were most affected by bronchiectasis, and included the Maori people and the Pacifica people in New Zealand, because they were also very severely affected by bronchiectasis. They're randomized to 2 arms, and you can see there that it halved the exacerbation rate and also almost halved the hospitalization rates, and it also improved their weight. So it was a major change, and now it's actually standard care. So the future and the hope, I've spoken to you that low lung function is really important, and we have to achieve good lung function. And the things that causes low lung function is things like lower respiratory infections, but persistent infections and persistent inflammation also leads to poor lung function and future lung diseases like COPD. The key other things that affects it is preterm births, environmental exposure, and what we call exposomes, which is a whole host of other things which I'll go and get to. So we really do need to actually tackle this, because we have to improve their lung function so the adults do not die of all-cause mortality down the track. We have to start from a very early age. So I've shown you a different version of this before. This is Professor Demarge's group, who's a very clever Sri Lankan doctor who's migrated to Australia. And her data shows just those curves that I showed you earlier, that if you start low, you maintain low. But the two key things that she found was in a subgroup of people. In the orange line, you can see that the lung function can actually improve in childhood. And also there's a different group where the lung function declines and therefore they die earlier. So that's why childhood and children is just so important. If you provide good clinical service, we have actually shown that you can actually make a difference. So this is again data from our respiratory service to the Aboriginal remote communities, and you can see that there was a difference in their lung function with a significant improvement after a year of care. And when we looked at the data of what we provide in the outreach service versus what we provide in our tertiary care, we actually found no difference between our IROC service and our hospital daycare service, with a significant difference for the improvement as well. So we really can make a difference as good clinicians in whatever field we actually choose to. So this is the framework that we use, that's published in the Lancet Respiratory Medicine now. You have to start with high quality evidence-based service. And the evidence-based service can always be accompanied by good research, because when you go out there, you see what the people need, you talk to them, and they will tell you what they actually need. And that's how we did our first service or research on the prevalence of asthma. You have to build capacity. You have to actually talk to the community, the health professionals that you go out with, as well as researchers. Health education has to accompany whatever you do, and appropriately. So very quickly, what we've done, we've actually done things like provide education services. We've done apps in language. There are lots of challenges. So in summary, I hope I've shown you the importance of lung health, not just because of the burden, but also the impact, the paradigm of the factors influencing lung health, the need to improve lung health through social determinants by as well as interventions that optimize lung growth, the contributions of the Indigenous people to global research, and how you and I can make a difference. And I thank my research teams who are just wonderful. That's my team in Brisbane, and that's my team in Darwin. Thank you.
Thank you so much, Dr. Chang. Thank you for coming all the way from Australia and giving us the many meaningful insights. Thank you once again. It's my privilege to invite the next speaker for this session, Padma Shri Professor AP Dash, Vice Chancellor, Asian Institute of Public Health, all the way from Bhubaneswar, Orissa. Please help me welcome him. He would be presenting on the topic, Eliminate Neglected Tropical Disease to Achieve Sustainable Development Goals.
Very good morning. At the outset, let me express my gratitude to the organizers for their gracious invitation to come over here and interact with you for a little while. I wanted to speak on to end NTDs, neglected tropical diseases, to achieve sustainable development goals. And I agreed to attend this conference for two reasons. Number one, I happen to be the director of the National Institute for Research on Tribal Health in Jabalpur for a couple of years. And then to achieve these sustainable development goals, it is necessary to eliminate or control the neglected tropical diseases, and it is necessary to upliftment of the marginalized community and the tribal population. So if you see the neglected tropical diseases, these are the successors of the Millennium Development Goals, the Sustainable Development Goals, which are the successors of the Millennium Development Goals. They have 17 goals and 169 targets. And the neglected tropical diseases affecting the marginalized community or the poorest of the poor are very important elements for achieving the sustainable development goals, because they are directly and indirectly connected to 12 goals out of the 17 sustainable development goals. But the thing is that I have to condense my presentation within 18 minutes, and so I have to skip some slides and to be very fast in doing that. Now, if you look at this slide, we have on the left side ears and dracunculosis, which are targeted for eradication, and ears was India was declared free from ears in 2016, and dracunculosis way back in 2006. But in the middle, we have lymphatic filariasis. My presentation makes very easy after the presentation of Dr. Mehta yesterday, who already defined certain most of the neglected tropical diseases in Tanzania while in his presentation. Thank you, Dr. Mehta. And on the left, we have the diseases targeted for control and prevention, and the diseases targeted for elimination and also elimination as public health problem. These are the sustainable development goals, 17 goals that I have told you. And we are definitely, all of us will agree that we have entered an age of polycrisis, and we all of us will see about the conflicts, the climate change impact on various aspects, and also the lingering effect of the COVID-19. We are yet to recover from the post-traumatic shock of COVID-19, economically or health-wise or whatever, and we are already crossed the half line of achieving the Sustainable Development Goals, our 2030 agenda, and progress is almost is more than 50% target is done. And when these are the different sustainable goals of the sustainable development, and we have these are the countries in Southeast Asia region. As you know, WHO is divided into 6 important regions of the divided the world in 6 regions: American region, European region, African region, Eastern Mediterranean region, Southeast Asia region, and Asia, and Western Pacific region. In Southeast Asia region, this is the progress. I cannot go into the details of it, but when you see about the entities in India, we have dracunculosis. We have already almost eradicated that. India is free from dracunculosis years, as I have already said. Visceral leishmaniasis in Kala-Azar, India has reached the point of elimination as a public health problem and waiting for WHO certification. Lymphatic filariasis is endemic in 272 districts of Odisha, out of which 98 have already reached the point of elimination, means we are progressing well. Similarly, leprosy and rabies. Trachoma, India was declared free from trachoma to be eliminated as a public health problem very recently. I will show you in future slides. And schistosomiasis is no longer a problem. It was found in Maharashtra itself but there is no malaria is drastically coming down. And as I said, Sustainable Development Goals, 195 countries are signatories, including India, and so entities are related to goal number 3, 1, 2, 4, 5, 6, 8, 9, 10, 11, 13, and 17. As I said, 12 goals. Now, what is the eradication? Eradication means a permanent reduction to the zero level worldwide incidence of a specific pathogen with no risk of reintroduction. Elimination is of transmission is a reduction to the zero level of a particular infection, and that is in a defined geographical area with minimal risk of reintroduction. But elimination as a public health problem, you reduce the disease to a certain extent so that it's no more a public health problem. Control means those who are not targeted for elimination or elimination as a public health problem or eradication, you must prevent and control the disease so that the mortality will be reduced. In January, on 28th January 2021, the World Health Organization has developed a roadmap for entities for achievement in aligning with it with the achievement of Sustainable Development Goals, and where three things they have said: the programmatic action should be there, cross-cutting approaches should be there, and countries' ownership should be there. Each country should take their ownership to achieve the Sustainable Development Goals, all 13 goals. And it was passed in the 24th World Health Assembly, and they have taken a decision to recognize one World NTD Day on 30th January to be observed. And WHO has developed a roadmap, as I have said, and they are related to many goals. And here, the target by 2030, if you say, the fewer people requiring interventions against neglected tropical diseases, 90% should be 90% reduction, and 75% fewer neglected tropical diseases related to disease, and 100 countries having eliminated at least one NTD by 2030, and 2 entities has to be eradicated. These are the main targets. I cannot go into the details, but you see at a glance about the progress. In 2019, 170 billion people required interventions against neglected tropical diseases, down from 2.19 billion in 2010. So this is the progress already made by 2019. Over 1 billion people benefited from at least one NTD intervention. Now, if you see the again progress highlights, 105 countries require preventive chemotherapy, and 81 countries implemented large-scale treatments. 649 million people no longer require mass drug administration for lymphatic filariasis, and at a glance, if you see 43 countries and territories and areas have eliminated at least one neglected tropical disease. By 2020, in 21, added Gambia and Cote d'Ivoire for eliminating human African tuberculosis. In 2024, India also eliminated trachoma. So 43 plus 6, 46 countries. And then coming to lymphatic filariasis as an example, I'll give you 2 examples. One example for a disease targeted for elimination as a public health problem. One disease targeted for prevention and control. Lymphatic filariasis, as you know, is caused by nematode parasites and transmitted by Culex mosquitoes, resulting in deformation of the wings. And this is the parasite and the vector. The paracycle is there. So once upon a time, lymphatic filariasis was never thought to be eliminated. People thought once we have this deformity, this disease, we have to live with it. But the research carried out in the treatment given for lymphatic filariasis, if you are lymphatic filariasis positive, go to the clinic, get a dose of banoside, the diethyl carbamazine citrate, for 12 dose treatment, and where from it came, there is no clinical trial for 12 days treatment. It was given like that, basing on a particular assumption, but there is no time to tell you about that assumption. See, I have only 10 minutes now. So after the research carried out during 1990s, it was found that a single dose of administration of diethyl carbamazine citrate is equivalent to 12 days treatment of diethyl carbamazine citrate. So there is a big project in Pondicherry, and mathematical modeling has shown that if you treat the entire endemic population by single mass drug administration by diethyl carbamazine and albendazole, you will achieve elimination of lymphatic filariasis as a public health problem by within 5 to 6 years. So then the hope for elimination of this disease came, and the global lymphatic filariasis elimination program started in 1990s. Today, out of 272 endemic districts in India for lymphatic filariasis, 98 districts have reached the point of elimination due to this single strategy of giving single dose administration of DEC and albendazole to all and to the entire endemic population once in a year. Now, if you see the revised global estimates of lymphatic filariasis, there are 74% reduction by 2020 as compared to 2000. The progress is quite satisfactory, and this is the population requiring the mass drug administration now. In Southeast Asia region, there are 11 countries. Out of the 11 countries, Sri Lanka, Maldives, Thailand, Bangladesh, and Timor-Leste, they have already eliminated lymphatic filariasis as a public health problem. So this is the cases of lymphatic filariasis in different countries, and India reached the point of elimination for Kala-Azar as a public health problem. In 2023, India has reported 595 cases as compared to 9,000 cases in 2014. Our country has reached the target of reporting less than one case for 10,000 population. That is the target to eliminate the disease as a public health problem by 2023. And India is waiting the WHO certification, because 2024, 25 and 26, they will monitor zero transmission, and then they will declare elimination of lymphatic filariasis as a public health problem. Coming to a disease which is targeted for prevention or control is dengue. All of you know about dengue. It is caused by 4 serotypes of dengue virus, dengue 1, 2, 3, 4. And among the serotypes, there are also many genotypes. They occur, and dengue 1 has 3, dengue 2 has 2 serotypes, dengue 3 has 4 serotypes, dengue 4 also have 4 serotypes. And they are transmitted by mosquitoes. It's not going. The Aedes aegypti and Aedes albopictus. Left side, if you see, left side is the Aedes aegypti that breeds in the breeding place on the left side, and the right side is the Aedes albopictus, which has one height line on the thorax. And this Aedes albopictus is a sylvatic species. It loves nature. It breeds where natural plants and things are there. So they transmit the disease. And if you control Aedes aegypti, you control dengue, you control chikungunya, you control Zika. These are the day-biting mosquitoes. Now I'll tell you how the dengue virus has different serotypes. It's spread all over the world. When dengue came as a pandemic for few decades back, the mortality was 18.4%. COVID, we know we had only 5%. You can imagine how dangerous was dengue at that time when it came as a pandemic form. Let's see how the different serotypes they had gone. If you see this, you say tsunami, earthquake, there is a what they call it epicenter. The maximum intensity is in the epicenter, and when this goes around, the intensity decreases. Similarly, for dengue, the epicenter is Thailand and Indonesia. Let's see how it goes. Now, this is dengue 4. It started, and then 5. You can see how the dengue 4 and all these serotypes, they gradually started, and Now today, by 2012, you have all serotypes circulating in every country of the world. This is dengue. And in India, if you see different years, you can quickly see 1991, 1996, 2001, 2008, and 2013. By 2013, almost every district is endemic for dengue, excluding some part of Jammu and Kashmir. So we had a meeting in on dengue. You know, you have where they are working to all other organization. We are working on dengue, and there is a technical advisory group, and where well, this I think I will not go into detail of these slides. And then elimination of Kala-Azar, I have said India has already reached the point of elimination is caused by Leishmania parasites and transmitted by phlebotomous flies. And we have the NTD elimination years-free status in India. We developed a strategy in 2000, way back in 2012, and where, you know, years was treated by penicillin injection, and it is very difficult to give the penicillin injection. Then we found out that only single dose of azithromycin can cure years forever. So that strategy was developed. Now it is used everywhere, and years is coming down in all endemic countries. Now this is a momentous occasion for India, while India was certified by WHO for elimination of trachoma very recently. So we know climate change is happening, and it is a very big impact on vector-borne diseases and neglected tropical diseases. So it is predicted that within coming few years, temperature is going to rise by 3 to 4 degrees. But what is important is that the warm nights are increasing and the cold nights are decreasing. This is an important thing. There are 5 pillars of sustainable development goals. 5 P's: people, prosperity, peace, partnership, and the planet. This is sustainable development goals are briefly on these 5 pillars. Now, entities are crucial for achieving the sustainable development goals, as I have already said. And India we analyzed in 2017 that analyzing many 195 countries, what is the progress of sustainable development goals. Unfortunately, India's serial number was 120, securing only 60 scores at that time. Then what has happened? And now, of course, it is improving. Now it was 60 by 2018, then became 66 in 2021, and now in 23-24, the score is 71. I think India is progressing well in achieving the sustainable development goals. If you say good achievers are 100%, front runners 65 to 99%. So we are in the front runners in achieving sustainable development goals by 2030. And progress in India, I have already said. And so there's an association of Indian universities. They met in Mysore in 2022, had a Mysore declaration, and pledged that some amount of research will be dedicated for sustainable development goals. So India can be among top 10 countries by 2030 to achieve sustainable development goals. So with this, I think I am before time. I thank you very much for the present hearing. This is all about this is just 45 minutes talk. I try to package it in 18 or 19 minutes. Thank you so much. Now, finally, I thank all my colleagues who has worked with me in all the institutes I headed. Thank you so much.
Thank you, sir. Thank you so much for sharing your perspective on the topic. Thank you. Our next speaker for the session, I would like to invite Professor Pathirag Kamal Pereira, Dean, Faculty of Indigenous Medicine, University of Colombo, Sri Lanka. Please help me welcome Professor Pereira. The topic of his presentation today is Recent Advances of Indigenous Medicine Practices and Research in Sri Lanka. Welcome, sir.
Ayubowan, Namaste. Good morning. So today is a bit important day for all of us because this is a very important conference happening in here. So first of all, I would like to thank all the organizers inviting me, representing the Sri Lanka. Today, actually, I must talk about the recent advances, especially in the indigenous medical sector, who practice and research on especially the traditional systems of medicine in Sri Lanka. So in these perspectives, I would like to talk about the current status of indigenous practice in Sri Lanka as a case study. So then again, the integrity and strength in traditional medicine research development process. Then again, I would like to discuss the success stories which are involved in some research development processes. So before that, maybe I would like to introduce this setup as a country in Sri Lanka. So why I select this, actually when you are doing research, especially the drug development processes, the baseline is the traditional medicine, always, most of time. Maybe not only our country, the globe. Because now the reverse pharmacological systems approach are in very high in the this platform because of the global economic crisis and different perspectives. So within this, you can see when it comes to Sri Lankan traditional systems of medicine, we call it Sri Lankan Ayurveda, basically. It consists of the tribal level of indigenous practices, and we call it Desi Chikitsa. Then again, the Ayurveda has come from the Indian continent. Then again, the Siddha and Unani. So all together, we are telling it's Sri Lankan Ayurveda now, because now the system has been changed. In earlier, we do have only the Desi Chikitsa. Now it's a bit of mixed culture in our country. Because you know that in our country is the middle of Indian Ocean. Most of these travelers going through our country, this mixed culture is now with this type of medical systems. So I would like to tell you research which has been done in myself and my research team, especially the concern of the WHO, traditional medical research, and as a case study of the Sri Lanka. Within this, I want to emphasize some factors in our country concerns. In Sri Lanka, especially when we are doing any sort of research, we are governed with the ethical framework. We are conducting the Code of Conduct of Sri Lankan Research. We call it CCHRS. Within that, we are framework designing and everything, the protocol development we have to done accordingly. So then again, we had to go for the international guidelines and ERC guidelines before doing any sort of research on maybe tribal or any other concerns. So not only that, there's a governance framework also. Ethics review committees are the main government bodies in Sri Lankan research concerns. Then again, the clinical trial registries, every time when we are doing any sort of trials, we have to register under the clinical trial registries. Not only our country concerns and also the global, other WHO accepted clinical trial registries we are targeting. So when we are done this scoping review of this as a case study, we found that especially in this kind of medicines, the lack of evidences, evidence-based practices. So we have to fulfill this, that meticulously we are doing these clinical trials in correct pathways. So in that purpose, we found that very few trials have been done, not only our country, other country concerns also, they especially concern the traditional systems of medicine. High level of case reports we found. Actually, this is the basement of the developments of new research. The case reports are very important when it comes to the continent of the traditional systems of medicine. Because always these systems are case-based level studies, like a pharmacogenomic type of studies. So then again, we found that some sort of issues pertaining to the safety of herbal medicines, as maybe the India concerns the same, I think. You can see that especially plant toxicity and lack of basic experiments, then again, the non-systematic pharmacovigilance systems of this, sometimes lack of standardization and quality control systems, lack of manufacturing practices, Then again, sometimes the standard pharmacopoeia. The pharmacopoeia is not updating currently. That is not, these are the major things that when it comes to the traditional systems of medicine concerns. So when it comes to common perceptions, actually, when you are thinking about our practices, traditional practices, maybe tribal practices, we think that actually these had developed over time by trial and error. But now are the time tested. Maybe sometimes it's a part of cultural heritage. So maybe these are the truth sometimes. We have, I mean, that if we go through the evidences, we found that these are very correct. But this emerging things happen in the world, right? Maybe genetic variations and different modalities comes within that. Sometimes above perceptions of traditional medicine leading to vacuum of scientific evidences. That's why we need a high level of research, especially evidence-based type of clinical trials, type of research works in future. So in the sense that we are doing some sort of research within our university level. When it comes to the country concerns, in every university we do have the university business link and also research centers. We are collaborating each other. We are developing different type of drugs and research, especially clinical research. So in this process, especially the innovative process we are adhering, using these traditional leads compounds. So in this case, we are developing standard products, then ethical approval, as I said, the trial registries, then again, conducting and data management. There should be a data management center, then product registration processes, then pharmacogenics and safety studies. All these are come together. We're not thinking about this evidence-based drug development processes. Not only that, the current CDD document, common technical document, come from the ICH, especially the International Conference of Harmonization. These all models we have to adhere when you are doing traditional leads related drug development processes also. Then there are some new guidelines we have to adhere, especially the WHO concerns. Then we are developing your protocols. We have to think about the laws, regulations, ethical standards. Not only that, especially GCP practices is very important. Even the traditional practitioners, they have to get the knowledge when you are doing research. Good clinical practices is essential. So otherwise, it's become problematic to the general public. The ethical guidelines you have to follow. Then not only that, this is very important, that innovation and intellectual property rights issues. This is a very important factor, which I worked in 2015, somewhere there with the WHO. We found that still there are some biopiracy things happening in the world, not only our country, there are other country concerns, because they are getting exorbitant prices that when you are developing this medicine through the especially traditional, things of knowledge. So we have to protect this very well. So then again, I will share with some sort of things which we did in due to develop the evidence-based approaches, especially in primary health care, clinical product development processes. So in this case, this is the first trial at the very beginning we did with the using some traditional medicines, especially in our country concerns. It's about the efficacy of 2 Ayurvedic drug regimes of uterine fibroids. This is a type of randomized single-blind 3-arm clinical trial study protocol. In this case, that we match 2 systems, traditional systems of medicine and allopathic systems of medicine. Because when you are doing this business, when you are doing this trial, we cannot get a single entity drugs. It's some sort of protocol. We adhere that protocol and we compare to allopathic protocol. We found that actually it's very specifically, our conclusions are very sounding towards the traditional systems of medicines is the best in some level. But beyond that level, actually the traditional practices cannot do anything. Especially the volumetric 7 level that we can reduce this fibroid using traditional systems of medicine. This is very good innovations we did. Now we are trying to develop this further to maybe as a service and product. So then again, another trial which we concluded recently that through our business cell, University of Colombo, using the traditional systems of medicines. Especially this trial, we compare with the Western allopathic drugs that we call loratadine. It's also having a good results. When you are using these allopathic drugs, especially side effects, adverse drug reactions is coming. But in this case, that in the traditional arm, that we can control these callbacks. This is very important trial within our University of Colombo business link. We are now try to commercialize this with our rights, university rights. So in our university model is that when you are doing innovations, especially, we had to go through the university business link and do some sort of guidelines. We had to make the MOUs. When you are putting these drugs to the market, even we had to be monitored. In that sense, we are working with this critical drug development processes. Then another thing that we developed using herbal medicines, this case that is some sort of drug we developed for the diabetes mellitus. This is the trial that we run in efficacy and safety of freeze-dried form of Tragia in Cartra. This we modernized a little bit of this product for primary healthcare to serve to the primary healthcare. So then again, another success story that we found another traditional medicine, especially this is we call Sudarshana suspension in our drug development processes. We found this drug is very good for pediatric febrile conditions. So we got the patent and we are marketed this through our business lane with the rights to our university. So then again, it's another thing, very important thing, maybe your country concerns also. Actually, the problem with the tobacco chewing, and you know that every time with the tobacco quid is become a problem. It's caused lots of problem issues to the general public. So you know that as a human nature, that it's not easy to implement something, right, without giving substitutes. So we thought that we discussed with the health community and we developed these products to substitute that that quid. So this is now available through the National Authority on Tobacco and Alcohol. So this is a good case study that this involved in the oncologist and myself as a team work. We developed this product. So there are a few more innovations we did through these traditional systems of medicine. So that's why I want to emphasize here, every time we have to give credit to these systems, especially the traditional systems of medicines. So this is the current trial we are focusing on for the osteoarthritis. This is also gained from the traditional leads of concerns of traditional medicines. In this trial, we are targeting the efficacy and safety of Sri Lankan traditional medicine regime for knee osteoarthritis. This is totally taken from the traditional medical practitioners. We have in some sort of discussion and communications, MOUs. Within that, we are processing these things. So not only that, we are targeting to develop to identification some medicinal plants, rare medicinal plants who is used in tribal setups, especially. Within that, we develop a app, especially using, you can see that convolutional neural network systems. So with this research, we can significantly influence to identify the rare plants materials using the phone app. In future, it will be helpful to the medical students highly. So then again, we did some sort of collaborations with the university, especially the Australia and New Zealand, to develop Prakriti app. This is very important. Maybe some of you are doing Ayurveda here. So now we are validating this app through the clinical trials. So maybe in the future, it's come to your phone. So you can easily find your Prakriti accordingly. This is actually very much slow lagging pace in between, because there are some rules and regulations we have to follow when you are doing country level research. So Actually, the evidence-based system of this traditional medicine, globally it's happening. Recently, we conclude this systematic review, study design of herbal medicines in clinical trials, descriptive analysis of published studies investigated the effects of herbal medicine products on human participants. We found that a significant level of good research that has been done in a global level. So it's very important that this type of traditional systems, these tribal medicines, is becoming evidence-based medicine in the world. So it's a leading factor to maybe develop a new protocol or new drugs. So this is a very important factor because most of the time we think that traditional medicines and these tribal medicines is not scientific. So when we are doing research, we find that these are very important materials to use within the frugal innovations. So this is very important. So then again, currently we are conducting with the frontiers medicine that the increasing relevance of traditional medicine systems of the primary health care sector and general practice global research perspectives. Maybe I invite you all can send your articles to this journal. Still we are running this. It's a high impact journal. We are running in the frontiers. So actually first part one we concluded that in this part one also, we got a higher number of clinical based studies, special concerns of the traditional systems of medicine. So this much of level that it's target this tribal or traditional medicines in the world now. So finally, but anyway, that I want to emphasize again this IPR issue. So we had to sort out well that otherwise that higher technology and that having some other countries, they are getting this our things and they are making this money generating purposes. So we had to protect that also. So finally, I would like to invites maybe the collaborations, networking, the partnerships with you, with our unit within our University of Colombo. We are targeting some SDG goals in this unit. The research and development of natural products unit in our faculty instead of Indigenous medicine. So maybe in future, I'm thinking to collaborate maybe few universities who will come up with us that work this type of works. So these are the things actually I want to conclude here. So I would like to wind up with that the Hadasannya, this is our Sri Lankan tradition. There are some traditional knowledge behind these things, especially. These are not objective parameters. They are very subjective, especially the psychological conditions. Maybe we can utilize these modalities to improve primary health care in the globe. So I'm very much thanks everyone that here I'm representing this university, very prestigious university, University of Colombo in Sri Lanka, the number one university in Sri Lanka. So maybe in future you can collaborate with us in this type of works. I'm very happy to collaborate with you all. Thank you very much.
Thank you. Thank you, sir, for your time and insights today. Your presentation was incredibly valuable, sir. Thank you. QR. I would request our chairperson to kindly share his view about the session.
Thank you. Till now, since yesterday, you must have been listening to many speakers talking about tribal health. And during this session, you must have realized that tribal health is something which is not only, that indigenous tribes are not just seen in India. It's a worldwide phenomenon. Even the developed countries like Australia, they have their own indigenous Aboriginal people. The only difference is that while we are facing mostly issues of nutrition and communicable diseases amongst the tribal population, there they have different issues. Madam talked about the lung functioning disparity amongst the Aboriginals. I think even in India, we can think about conducting such studies about lung functioning, especially post-COVID, because upper respiratory tract infections are very common amongst these tribal populations also. something which is not very well understood. And if we can have some long-term studies, probably we will be able to infer from it whether it's applicable to our tribal population as well. As far as Dr. Dash's presentation was concerned, it was mostly about tropical medicine, which definitely is more applicable to the tribal health. Many of you must not have heard many conditions which he mentioned. But for the students, let me tell you that the good olden days, people used to go to UK to do diplomas in tropical medicine. So something which, as he very rightly called them as the injuries, these are the diseases which probably we'll have to look into, especially in the context of the sustainable development goals which India has to achieve and has to achieve very fast. As far as the last presentation is concerned, it's not my domain, but definitely the ingenious herbal medicine and other pathies which are quite prevalent in India, like Ayurveda, Unani, homeopathy, they need to have such studies conducted and presented. Like his presentations were mostly published in BMC, Lancet, and journals of international acclaim, so that eventually we too will gain more acceptability amongst the people for these pathies. If you have any questions regarding the same, I think the speakers are here and they would be able to answer you more. Thank you very much.
Thank you, sir. Thank you for precisely summarizing the session. I would invite our speakers on the stage, Dr. Annie Chang, Professor A.P. Dash, Professor Pathirag Kamal Pereira. Please come up on the stage. I would request our chairperson, Dr. Anil Deshmukh, Dean PDMMC Amravati, to felicitate our speakers with token of appreciation. Please help us in felicitating our esteemed speakers, Dr. Annie Chang, all the way from Australia. Please felicitate our next speaker, Professor A.P. Dash from Bhubaneswar, India. Professor Pathirag Kamal Pereira, all the way from Sri Lanka. I thank all the speakers for coming up on the stage. Thank you, sir. I would invite Dr. Jalita Chinyong, former Director, Ministry of Health, Health Expert General and Social Affairs, Zambia from West Africa. Ma'am, please come up on the stage and felicitate our chairperson, Dr. Anil Deshmukh. Thank you so much. Thank you, sir. We have a QR code displayed on the screen, as well as we have QR codes displayed across the campus. I would request all the delegates to please scan the QR code for the feedbacks. This will help us in further improvements. So it's a kind request, please scan the QR code and give us the feedback. Thank you so much. So here we end with the session 1 of the theme lifestyle. Here we end with both the sessions. Sorry, here we end with session 1 of the theme lifestyle, tribal, tradition and taboos fostering the diseases. Now we shall be starting with the scientific session 2, for which I shall be calling upon Dr. Anand to please take over.
Let us now move forward with the academic discussions. It's our privilege to welcome you all to the second scientific session of the day of MUHS FIST 2025. The session is dedicated to a critical and often under-discussed topic, but a very important topic: sickle cell disease, prevalence and practice beyond boundaries. We are indeed honored to have with us distinguished experts in this field who have dedicated their life to this research. So to lead this insightful session, I'm pleased to introduce our esteemed chairpersons to the stage. Please help me welcome these chairpersons: Dr. Deepti Jain, Adjunct Professor, Department of Pediatrics, Shalini Tai Mege Medical College, Nagpur. And Dr. Jala Wilhelmina, former Health Minister, Republic of Liberia, West Africa. Please welcome our chairpersons with a round of applause. We have 3 talks in this session, and each talk with an allotted time of 20 minutes. To deliver the first talk, I would like to invite on the stage Dr. Ludmila Korang, who's joining us from Ghana. She's the chief pharmacist at Kolebu Teaching Hospital. She will share her experience on transforming sickle cell disease care in remote areas, combining technology, community involvement, and policy innovations. We welcome you to the stage, ma'am.
Namaste. I wish to have invited all of you to Ghana, but we know it's not possible. So I'm bringing Ghana to you. Okay. I'd like to dedicate my presentation to Koiku Ohene Frimpong. He was a pillar of sickle cell disease, not only in Ghana, but all over the world. Okay, my presentation is based solely on knowledge, experience, and opinions of the presenter, right? So that it doesn't necessarily represent all the affiliated organizations and institutions. Okay, I want you to look at this picture and see, we are going to talk about technology in sickle cell disease, right? When I asked my colleagues, what do you think they see? Someone jokingly said it's ECMO. You can see ECMO, real ECMO on the right side. We'll come back to this picture. So objectives is technology, community involvement, and policy innovations. We all know what sickle cell disease, right? It's the most common inherited blood disorder. Global burden is affecting people from African, Mediterranean, Middle Eastern, and Indian ancestry. And the most burden is coming on sub-Saharan Africa. That's where Ghana is. I wanted to show you. Okay. All right, so worldwide, it's estimated that 300,000 children are born with sickle cell disease annually, and 80% falls on sub-Saharan Africa. India is the next to us. In Ghana, the prevalence is 2%, and it's affecting, given the social and clinical impact